the lived experience of individuals is really powerful, and I was with you every minute. That was wonderful. Thank you. So I'm just going to warn you, I have a PowerPoint that I did, and I really, and the handouts are for the PowerPoints are, where are they, Alexis? In the back. So I've already used up some of my time, but I had a PowerPoint and I timed it, and I got, I had about 3 different PowerPoints on communication, etc. And I had honed it down to 20 minutes exactly, if I rushed. And then we at the office, some of our interns and staff person is here, had just started a videotape story bank project. And it became pretty clear to me that 2 of the first 3 videotape speakers were really, really essential for this presentation. So I brought them to you, but I'm going to speed through the PowerPoint slides and skip a lot of them and hope that you will actually look at them later, because they do have a lot of useful information. But so starting with thanking the Academy for the invitation, and thank you all for attending. I'm very excited to be here because this is such an important topic. I'm Kate Farinholt from NAMI, National Alliance on Mental Illness of Maryland. And I also got involved, as most people at NAMI do, because I have either I have an illness or I have a relative, and I have a sister who developed schizophrenia at the early age of 11. And it's been an interesting ride. Okay, so I have the controls here. Statistics. In this audience, 1 in 5 of you is going to be a family member or an individual with mental illness. NAMI has certain key components of our approach, and if you'll just glance at these, the last one, first of all, trauma is common to families and to individuals, not just trauma that might have happened in their past, but the actual trauma of having a mental illness, a stigmatized, stereotyped illness that also has often behaviors that change people's trajectory. And of course, the gold standard of care is collaborative. This speaks for itself. And most important, we believe that the subjects, the lived experience of people with mental illness and their families is absolutely essential in helping people out there in the world to understand and to think about how they might change systems and programs, but that our voice should be in the room, in the conversation about how programs might be changed. That's my sister and me. I won't give you my story because I have some even better videotape stories, but that's my sister and me about a year before, about 2 years before she developed schizophrenia. And while it's important to tell our stories, often it's hard. So just mentioning my sister makes me tear up. She's a wonderful person. Prevalent stereotypes about people with mental illness. They are their mental illness. They have no support network. They're dangerous, incompetent. But here we have, and now I'm not sure how do I get the video to go? You're going to get the video to go. Good. And this is Denise Valentine. Who's going to say something? Well, I can tell you before we get Denise talking that Denise developed mental illness in her 30s. She was had a quite impressive job at the Department of Defense. She ended up losing her job, but also homeless and sleeping under the bushes near Morgan State University in Baltimore. And she presents now as normal.
The video is embedded in the PowerPoint, so it's probably not going to play unless you actually have
I don't know which. I can push all these buttons. So there's a. How's this? I don't know what that does. The lived experience is really important. It's embedded in the PowerPoint, it is not linked to internet at all, purposely. So as they're talking, basically, Denise Valentine came to NAMI, happened to walk off the streets because someone had mentioned, you might, as she departed psychiatric hospitalization, that she might want to come and check out NAMI, where we provide free peer-led education courses for individuals, relapse prevention courses for individuals with mental illness and support groups, as well as for families. She came in and we talked for a while, and she apparently tells me later she was suicidal, and she decided to go to one of our support groups, and she would try just one day at a time. And she actually became eventually not only a volunteer, but then our part-time and then our full-time program director. We brought her back out of retirement at NAMI, Maryland. I guess I'm going to move forward. That's when it is posted, I will hope that the slides will be embedded. This is Claire Wilk. She's a family caregiver. She has 2 sons. She talks about her interactions with health providers as a caregiver. And not just around the HIPAA considerations and misunderstandings often of what HIPAA actually says. But her first son had a mental health issue and ended up committing suicide. Her second son, he does also have a mental illness, and she has very little. She's learned from our family to family course that she can share information, and so we help her prepare it and give it to the doctors. Whether that's taken into account is another question, or even looked at. But so she talks about not only how health providers have either ignored or treated her in some negative ways, but also what kind of information she needs as a caregiver. It's also a little advertisement for our programs because she thanks us for taking the courses. So these are prevalent stereotypes about families dealing with mental illness, and that they are to blame, that they're enabling, that they're too pushy, that they're too controlling, and they have no real useful information or resources. I can tell you as a family member that I was saying somebody this morning, I wasn't going to share this story, but my sister has schizophrenia. She's living in a group home, which is an unusual possibility in our area. But she doesn't get moved in and out because I'm the executive director of NAMI Maryland. But when she's symptomatic, the person who she trusts most in the world, which is me, and she calls me every day, and whenever she's fearful, etc., she calls me for support. But if she starts calling me more than a couple times a day, then I know something's going on. And if she starts walking in more than a little square, but starts walking bigger and bigger squares, I get worried. When she stops calling, then I know she's really in trouble, because that means she's decided that I'm trying to poison her, that I'm the enemy. And yet I can often not get, for many years, I could not get a psychiatrist or the primary care doctor to understand that I knew my sister's history, that I knew what the indications were. I didn't necessarily want to lock her up in the hospital, but I did have information that really concerned me. And but she has an amazing psychiatrist now who gave her his cell phone number and me, and we've never used it, but he's really inviting. Primary care, if I don't go with my sister, She will not get the mammogram. She will not get the regular stuff. They see her name, they see her diagnosis, and that's what they see. She has schizophrenia. Now, I happen to know that she's not a good self-report. I often do not hear when she's going to go to a doctor because I'm, the provider, the day provider may be busy or may not want me to be involved, whatever it is. And so I'll hear after the fact, oh my gosh, I know you have a fungal infection on your shoe, on your foot, and they didn't ask you to take your shoes off. So, I'm the one who often is the one who looks angry and aggressive when I'm trying to advocate for my sister. Another example is when she's gone downhill and but she's not far enough and she's come to my house and she's trashed it. And I've been trying to keep her, I've been up all night for a week or two. I have to finally call the police because that's unfortunately the only way you can get someone to, unless they voluntarily go, to the emergency room in handcuffs in Maryland. I called the police. My sister's trashed the house. I opened the door. My sister's calmed down, sitting on the sofa watching TV, and I'm the crazy one. The police often, I'm the one with the wild eyes and oh my gosh, and so I have to actually work on presenting myself. I have to focus on presenting myself as the calm, almost bystander in order to be able to first get them to recognize that my sister is the person, but also to convince them that I have some useful information. Like for police, she's scared of people who are carrying guns. So in NAMI, we view mental illness as a catastrophic stressor, and I can easily talk to you about Charles Figley has a book called Helping Traumatized Families, and he defines a catastrophic stressor like this. It's generally an unanticipated event which occurs with little time to prepare. It happens in an area where one has little previous experience and few sources of guidance, and it packs a huge emotional wallop. Well, I can tell you that even being told that your sister has paranoid schizophrenia and my dad back then, and there is no hope, and you might just as well sort of give up. That's a huge stressor. Also being told that you have an illness. Sometimes initially is a traumatic stressor. Sometimes it's very, very much of a relief because somebody is explaining why you have these symptoms. But we believe that trauma is part of mental illness and should be considered as part of mental illness, not just as a potential risk factor, not just as a potential trigger, but as the actual experience of having a mental illness, having things feel out of control. And I promise you, as family members and individuals, we do not get mental illness 101 in school. So we talk about these recognizable, predictable stages of emotional reaction to mental illness and recovery. You'll recognize them, I'm sure. This is NAMI's chart that we use in all of our programs, so people can see sort of where they are on the chart and what they need. We actually have a chart that includes this, but under each section, like crisis, chaos, and shock, we say what do families need, what do individuals need, and so people can see what they need, see what their family member might need, and talk about it and focus. It's also a very helpful thing for providers. This is you all talk about, I'm sure, about prevention. This is really important. I have never, well now I guess on the forms, I have to check whether I have a relative with a mental illness. But I do not believe, I can't remember any time any health provider, except her current psychiatrist, has actually asked, how am I doing? How is this affecting you? And what can I do? But NAMI has been very helpful. I'm not saying that people have, health providers have been very kind, but this is a very helpful chart, we feel, these are examples of what families may be families may be acting in response to the trauma of having someone in their family with a mental illness, and of the individual, and how they fit with normal trauma responses. If you can recognize that someone is shutting down, you can also then, and you recognize that this might be a reaction to the trauma of, for any trauma, but also of mental illness, you can actually accommodate that. And we do have trainings, but I will go on. And then, of course, there is secondary trauma. I'm not going to spend any time on it because my time is missing, going on faster. Can I negotiate a couple extra minutes because of I can blame it on the, okay, good. Thank you. That's the only lawyer part you'll see. I don't practice law. At NAMI, we also teach a lot of different topics that are there to help families and individuals. I will center in on the communication strategies. Most of the communication strategies are about how to communicate with your family member or with either way, if you're an individual with mental illness or your family member, and how to interact with someone who might not be making sense or isn't listening to you. Your family member isn't listening. But we also get to the point of working on how do you collaborate with your health providers, and how do you also become an advocate. And that includes becoming involved in program design as systems look at how they might change the way they deal with things. Now, unfortunately, here we go. I didn't write down what she said, but basically, she has depression. She's been really down and out, but I think this is the one where she talks about going to a gynecologist. Well, she was working, and she needed an excuse for going to this doctor. So for her employer, and she went to a gynecologist. And when she left, she looked at the paper that they had given her, and the diagnosis listed was not, anything gynecological. It was that she had depression. So she went back to her employer with this note that said, the reason she'd been missing from work was because she was depressed, which is mind-boggling, quite frankly. And it really also happened to affect her relationship with her employer because she had not revealed that she had a mental health condition. Talk about what families need, and I could go on and on. Families need to feel that they may be in such an emotional stew that they are very difficult to communicate with also, and so either refer them to NAMI and we'll give them a lot of information and support, but also just recognize that this is tough. This is really tough. I would have liked someone to say, in the 40-some years that my sister has been ill, someone besides NAMI, to tell me that this is not your fault. This is really tough stuff. It's really, it's good that you're available, but we understand how stressful it is. And here are some practical resources. Okay, well, let's see if I actually have some script for that. Let me just also go back. So I assume you are all cognizant of SAMHSA and HRSA. Whoops, what happened? I don't care, but, interpersonal communication and collaboration and teamwork are the first two core competency for integrating behavioral health with primary care. And I'm not going to go too more deeply to that, but basically, one of the statements is the ability to create and implement integrated care plans, ensuring access to an array of linked services and the exchange of information among consumers, patients, family members, and providers. And then they give there's a lot of really interesting, helpful, useful information. The next slide talks about how to talk to a patient with a mental health condition. And we have a lot of actual in-depth workshops on this specific topic, but core is that getting a sense of whether they're able to communicate, provide information, and understand what I'm saying, and making no early assumptions or stereotypes that someone is communicating or not communicating because of some stereotype. I apologize, I'm getting a little confused. The other is, do they need a supporter to assist them in reporting and or understanding? And even more than that, do they actually have a support system? My sister goes to the hospital. She's taken to the hospital quite often, not for the last 5 years. I mean, and there are a lot of hospitals in the Baltimore area. Either she's totally paranoid about me, and so she says she doesn't have any family, or no one asks her. And the second one is more likely. And so the first time while I'm frantically looking and calling hospitals and trying to find my sister, or I don't even know that she's gone because her provider doesn't tell me, the first thing I hear is that my sister has borrowed someone's cell phone or is calling from the floor phone and saying, "Why aren't you visiting me?" And when I go, no one actually knew that I existed. Well, by that time, if they'd asked my sister, I promise you, she would have mentioned me. The next one is, oh my gosh. Hey, Kirsten. Kirsten took these videos. Okay, which one are we on? Okay. If you click on the sound, yeah. And there's also sound on your computer. I really want you to hear these people.
I have had several negative interactions with health providers, but one is very pointed, it sticks in my mind. I had gone to a gynecologist for a regular gynecological examination, and she performed the examination, and when I got the paperwork back that I was to take to work as proof that I had been to the doctor, she wrote on the paperwork diagnosis depression. And I was wondering how a gynecologist with a gynecological examination could diagnose depression. She looked at my list of medications, she said, and wrote down that I had depression. She said, because you're hiding your mental illness.
Okay. Can we just roll the next, okay? And then I'll tell you when to stop. I'm ignoring the time.
Well, my psychiatrist frequently has to intervene in my care. Most recently, I had a problem with my lungs and my asthma, and I was coughing up blood, and my primary care physician ignored it. He said, it's not a big deal. And I insisted that he send me for x-rays and do a CAT scan, because my psychiatrist thought that was necessary. And he poo-pooed me and sent me on my way. So my psychiatrist at the next appointment, he said, did you get your CAT scan and did you get your x-ray? And I said, no. And so he called up my primary care physician, and I had my CAT scan and my x-ray. And then he didn't take it the next step further to see what was going on with me. So my psychiatrist had to find me a lung specialist to go to, and my primary care physician, he said, he called my primary care physician. He said, this is not normally what I would have to do. This is something you would do. And he says, well, I don't mind you doing it. I have a lot of patience.
You see why I want you to hear? And these are just these are two people who are there are two out of the first 3 videotapes that we've been doing. So it was priceless. Depending on communication. What are we doing? I may tell you to skip some just because of time. And while, oops. In the handout, there's also some screenshots of some tools that we have. And while we're waiting for this, we have a pocket card or a fact sheet. A lot of them, but the ones I picked was one. It was that we use for health providers, but especially for crisis workers, on how to communicate with an individual who has a mental health issue. But it's not based on if you have schizophrenia, if you have depression. It's based on what do you observe, what behavior are you observing, and what would be useful to do. And we give it to law enforcement and crisis workers, but a lot of mental health workers have been asking for that. I guess I'm back to here. This is about Denise going to the doctor with her mother along. As you know, we always suggest that if you're anxious or whatever, if you have somebody else who can go. And that's true for me. When I am going to a doctor and I'm concerned about something, I bring my husband. Well, but hopefully what happens to Denise is that the doctor talks to her mother, doesn't talk to Denise. Denise is can't possibly talk for herself. Her mom has to say, could you please talk to Denise? Sorry. Some very specific suggestions about what helps in terms of respectful and empathic communication, and I'm not going to go in there because I didn't write them down. But some of them are in our materials. This is, Denise talks about something that a lot of health professionals now do, but a little bit different than what you were describing, which is having someone fill out a questionnaire before they walk in to the doctor's office, in the waiting room or whatever. So you have time to write down the answers and think about it. And then it comes in and the doctor can look at it and discuss it with you. But also, what is it that you're here for today? So, it's very helpful, and a lot of health providers use it, but not all, I promise you. Basically, as a family member or supporter, I've already said, I need information. I don't need to know how my sister is really angry with me right now, or what my sister's specific thoughts are happening that she's talking to her doctor about, her psychiatrist or her health provider. But I do need to know, and I have the authority, the written authority. I need to know stuff like what medications is she on, what's the dosage, and what should I be watching for in terms of side effects. I'm her support. Now, admittedly, she's not living with me, and there are reasons why she's not living with me. Maybe now she could live with me, but she was extremely jealous of my kids when they were little, and she acted in ways that really concerned me. And so my sister is in a group home and goes to a day program, and they're really great, with the exception that they absolutely do not communicate with me at all, and I have to find ways to get information to them. Last week, my friend who is also a beautician who has mental illness, I pay her to go to the group home and do, help the various patients, but especially my sister. So she goes regularly, and she called me and said, I didn't put nail polish on your sister because her nails, under her nails was all blue. And I'm really concerned about her health. I don't know what that means, but I mentioned it to somebody in the house, and they said, well, we'll tell, this was on a Saturday, we'll tell her case manager, we'll put it in the notes. So I sent an email to the case manager, and I literally have not gotten any response, and it's been 2 weeks. I took my sister to my primary care doctor and paid off the books so that they could check to see whether there was a problem. So we have a vast amount of information. Please consider asking someone if they do have a support system, even if they're not there, and perhaps there's some information that you can send home with them. And it doesn't have to, it can even be about useful resources, but we are useful resources. And so I just mentioned all of that. And this is a specific list that we teach in our provider education course, which we have for providers, by the way, that is taught by family members and individuals with mental illness who have graduated from our courses, and some of them are also providers, health providers. And this is from that course, and it's in your handout, so I'm not going to go through it, but this is really, if you can give even a few of these things to a family member caregiver, you will not only help the patient if the patient is not that family member, but if the family member, whether or not they're your patient, if you do some of these things, the family member, the caregiver's physical and mental health will improve. And we have proof. So I'm going to run through some, okay. And thank you for giving me the extra minutes. So this is a screenshot. Sorry, it's not the best, but this is a pocket card that we, in the form of a pocket card, that we actually give out in police trainings and mobile crisis team trainings about how to talk to families who are in crisis. They called you. I'm the one greeting you at the door. This is how you can interact with me, because believe it or not, I'm reasonably coherent usually, but in this context, I am not as coherent. And if you ask me what's going on or what's the problem, I'll start at age 5 with my sister, who's in her 60s. So this is really concrete information, both how to communicate with families in a simple, quick way. If you can read it a little bit, we actually have something to say. You're really been going through a lot. You're trying your best to help, or it's not your fault. Lower the de-escalation, and then what to tell the family after intervention. And then, okay, I guess we're not going to be doing these. A lot of what I said, but really from the heart and from personal experience. Here, I believe that Denise talks a lot about seeing the person and not just the illness. Talking, we're going to try.
I think we're going to have to also move on.
Yeah, no, I'm going to say, let's just, this is the second to last slide. So, and they've frozen the time, so that's very confusing. Kirsten, let's just cut it. Yeah, people can look at it if they want. I hope you will. The next slide is the last slide, or almost the last slide. And frankly, in these last 2 slides, we did not ask them to do this, but they talk about how helpful NAMI programs were for them to really get a clearer sense of their illness and what they can do, how they can communicate better with providers, and getting support and practical suggestions from people who are going through the same thing as them. And that is the end. And I apologize for the technological snafus. I should have written down what they said. But anyway, thank you, and appreciate it.